Guys, and welcome to my channel. And today we are with a new juice. We are starting with the marathon session of systemic pathology. And systemic pathology is a very interesting and a very a big unit, but we'll try to complete the systemic pathology in detail with the notes. I will not write because it will take more time. Our target is to revise and retain as much as we can in the dearth of time, or in the in a less time, in a very beautiful way, right? So let's start the systemic pathology with my very favorite chapter, that is the CNS pathology. And after the CNS pathology we'll go to the next topics. So let's start with the CNS tumors first. It is a small chapter, not much big chapter, but it is a very important topic and a confusing topic also. Don't worry, I will try to make you understand all the things, and you don't need to worry much. Okay, so let's start with CNS tumors. So most common CNS tumor are the metastasis, the metastasis, and CNS tumors generally metastasize to the lungs, okay, to the lungs, to the kidney, and many other organs. Location of CNS tumors gives an idea of the symptoms of diagnostic importance, right? Like if there is a tumor in the ventricles, the patient will present with hydrocephalus, because if it is in ventricle, then CSF flow will be obstructed. If it is in meninges, then the patient will present with headache, right? A characteristic headache. The grading of tumors according to WHO is about 4 grades. 4 grade of tumors are there, and based on these 2 factors. Okay, grading of tumors 4 grade, but based on 2 factors. Grade 1 tumor and grade 2 tumor are basically having atypia and mitosis. Okay, mitotic figures you will see, and atypical cells you will see. If there is an association with endometrial proliferation, it is grade 3. If it is an association with necrosis, also necrosis, okay, it is a grade 4 tumor. Understood? Let's talk about glioblastoma first. So glioblastoma previously was known as GME, or glioblastoma multiformans. Okay, so it happens in the cerebral hemisphere. It is a grade 4 tumor. Remember, grade 4 tumor according to the WHO. Glioblastoma may be primary or secondary. Primary may be associated with IDH, wild type, non-mutated, but secondary means there is an IDH mutation. Wild type means non-mutated. Remember, prognosis is 6 to 2 years. Here it is 2 to 4 years. Imaging, you will see a butterfly like appearance, because it is a tendency to spread bilaterally on the CT scan. So it appears a butterfly like appearance on the CT scan, you can see from here. Okay, the microscopy will show necrosis, because there will be a necrosis associated with it. Since it is a grade 4 tumor, there is a presence of necrosis, so it will show necrosis and a pseudo palisading pattern. Look at this. This is a pseudo palisading pattern, a false fence like pattern, and a background necrosis is, you can see. Okay, a background necrosis with a pseudo palisading pattern. Understood? Immunohistochemistry, all the gliomas have a characteristic finding of GFAP. GFAP means glial fibrillary acid protein. Okay, understood? Let's move on to the next tumor, that is oligodendroma. Oligodendroma has a better prognosis as compared to any other glial tumors. Origin is again the cerebral hemisphere. It presents as seizures, very important. The characteristic history is given of seizures. What are the genetics? Again, it is same like the secondary glioblastoma, IDH mutation, and a very special chromosomal 1p19q co-deletion. Means either it may be chromosome 1p co-deletion or chromosome 19q co-deletion. The 1p arm, that is the small arm of chromosome number 1, or the long arm of the chromosome number 19, it may be co-deleted. It has 2 variants, grade 2 and grade 3. Okay, either it may be associated with your you can say endometrial proliferation, or it may not be associated with endometrial proliferation, right? Microscopy, you will see perinuclear halo. Perinuclear halo means, what is this? This is a fried egg appearance. That is, if this is the nucleus, then the cell will be like clear. Okay, it is like a fried egg. Okay, this is called perinuclear halo. So perinuclear halo is present, fried egg appearance, and due to dense capillaries, here the capillaries are present in network like fashion, so it is called chicken wire appearance. Very important. Look at this, the perinuclear halo, you can see. Can you see the cells? Having a look at this cell. Okay, this have a perinuclear halo, and chicken wire appearance, you can see all the capillaries present over here like a meshwork. Immunohistochemistry, again GFAP positive. Let's come to some of the tumors of childhood, like tumors from the posterior fossa. The location is posterior fossa, important. Okay, so here we'll compare and contrast between the pilocytic astrocytoma and medulloblastoma. So pilocytic astrocytoma occurs in the children. Okay, pilocytic astrocytoma is basically the categorization according to WHO. It is categorized under some according to 2016 WHO update. Okay, it is categorized not under the astrocytomas but another tumors of childhood. Okay, we don't need to go into that classification much. Just know that it occurs in children. It is a grade 1 tumor, only atypia and mitosis. Understood? So you can write here atypia and mitosis in microscopy as well. Gross is solid and cystic areas are present. Okay, heterogeneous appearance in MRI. This is important. It has a heterogeneous appearance on MRI. Okay, just a minute. So what it has? It has a heterogeneous appearance on MRI. Heterogeneous appearance on MRI, since it has solid and cystic areas. It is a heterogeneous tumor. Microscopy is Rosenthal fibers. What are Rosenthal fibers? These are pink elongated eosinophilic fibers. So you can write also eosinophilic. Pink elongated eosinophilic fibers, which are called as the Rosenthal fibers. These are the Rosenthal fibers. You can see here. These are the Rosenthal fibers. And microscopy here, or medulloblastoma, small round blue cells are present. Small round blue cells plus Homer-Wright rosette. Important, Homer-Wright rosette. Okay, this is a Homer-Wright rosette. This is a Homer-Wright rosette. Okay, and these are the small round blue cells. So medulloblastoma, small round blue cells with Homer-Wright rosette is important. So rosettes, if we talk about the rosettes in the CNS and tumors, so it is like a flower. Okay, a rosette is like a flower like pattern. True rosette is called when the central lumen is present. Central lumen is present. Pseudo rosette means central lumen is absent. Pseudo rosette means central lumen is absent. Look at this. This is a Homer-Wright rosette. This is a false rosette or pseudo rosette. Okay, it doesn't have any lumen here. You can see it doesn't have any lumen here. It has a background necrosis present. Homer-Wright rosette is seen in medulloblastoma, which is earlier, and neuroblastomas. These are also childhood tumors. Okay. Then next one, flexor intestinal rosette. Flexor intestinal rosette, it is a true rosette. Here you can see the lumen is present. This is the pale areas. Look at the pale areas here. So it is a flexor intestinal rosette seen in retinoblastoma. Retinoblastoma is a tumor of eye. Okay, due to RB gene mutation. Look at this. True ependymal rosettes. These are ependymal rosettes seen in ependymomas, and these are shaped like this. So true ependymal rosettes, and it has a lumen present. Okay. Next come to perivascular pseudo rosette, means around the blood vessel the rosette form is formed. The cells arranged like a rosette around a vascular core or a vascular core. Okay, rosette with vascular core. This seen in Ewing sarcoma, that is a bone tumor. We'll talk about that, and ependymoma. Ewing sarcoma and ependymoma. Understood? Next comes meningioma. It is an important tumor. Put some stars here. Meningioma. Okay. So meningioma origin is from meningoepithelial cells of arachnoid. Meningoepithelial cells of arachnoid attached to the dura mater. This line is important because it has been asked in the INICT. It is attached to the dura mater. So there was a PG question I had saw that attached to the dura mater line was given, and you have to identify what is meningioma. History of chronic low grade headache. Okay, there will be headache, but there is chronic low grade headache. What are the genetics? It is a part of NF2 pathway. The NF2. It's a part of NF2 mutation. Cells are positive for progesterone receptor. Important. So tumor increases during pregnancy. Since during pregnancy progesterone increases, so tumor increases in size during pregnancy. What is the gross dural based lesion? We talked attached to dura mater, well circumcised rubbery consistency. Remember, every CNS tumors have a well circumcised rubbery consistency with a grey, white and solitary nodule. Okay. What is the microscopy? Whole appearance means Samoma bodies will be present. Samoma bodies are a result of dystrophic calcification. Okay. So whole appearance plus Samoma bodies. It is a WHO grade 1 tumor. It is a WHO grade 1, grade 2, grade 3 tumor. Means it can be of any type. It can be of any type. Either it may be WHO grade 1, WHO grade 2 or WHO grade 3. Okay. What are the types? It may be meningoepithelial meningioma, or it may be fibroblastic meningioma, or it may be psammomatous meningioma. Okay. Either it may be meningoepithelial, fibroblastic or psammomatous. Okay. And if it is between this meningoepithelial and fibroblast, it may be called as the transitional meningioma. So 4 types, WHO grade 1 tumor, 4 types, so 4 subtypes you can say. Then WHO grade 2 meningioma, it may be atypical, clear cell or chondroid. Atypical, clear cell, chondroid, ACC, you can remember like this, okay? Atypical, clear cell, chondroid. WHO grade 3, anaplastic or papillary. It may be anaplastic or it may be papillary. Understood? So look at the microscopy. It has a whole appearance. You can see the psammoma bodies present over here, right? Psammoma bodies are a result of dystrophic calcification. Talking about schwannoma. Okay, last tumor is the schwannoma. Location is a cerebellopontine angle. Cerebellopontine angle, cranial nerve 8. This thing is important. This thing is important. So it is also called as acoustic neuroma. It is also called as acoustic neuroma, but this term is a misnomer. Remember, this acoustic neuroma is actually a misnomer because it is not a neuroma firstly, and so it is not associated with cranial nerve 8 always. Okay, it is not acoustic neuroma. It is called as acoustic neuroma commonly. Okay, symptoms are hearing loss and tinnitus. Tinnitus is the ringing bell sound in your ear. It may be a part of NF2. Okay, it may be part of NF2 or it may be sporadic. Microscopy will see a very characteristic appearance, Antony A areas and Antony B areas. Okay, Antony A areas means the area of hypercellularity. Let's say this is the Antony A area and this is the Antony B area. So this will be like present alternately like this. Okay, then above this also it will be present, above this, and lower cellularity, then high cellularity, then low cellularity. So you can see there is a appearance like this, dark appearance, then dark, then dark, then dark, and between this dark appearances are pale appearance because there is a hypocellularity area, right? So this is called as a Verroque body. This is called as a Verroque body. So I told you how the Verroque bodies are formed. Okay, this is a Verroque body, and Verroque body are palisading Schwann cells. Verroque body are palisading Schwann cells. IHC is S100. There's a sustentacular cells or supporting cells are positive S100. Okay, the IHC is S100 positive. This is a Verroque bodies. Look at these areas. This area, if I tell you about, this is an Antony A area, and this area is an Antony B area. This again is an Antony A area. This again is a Antony B area. Okay. So that were about our CNS tumors. Let's move. We completed the CNS tumors in 12 minutes, and let's move now to the other chapter, right? Hello guys, and welcome to the new unit of rheumatoid arthritis and bone pathology. So we are starting the bone pathology with rheumatoid arthritis. So what is a rheumatoid arthritis? It is an autoimmune inflammatory condition of your bones and the joints. Okay, it is a chronic condition and the systemic disorder. Important. It is also involving joints, skin, heart, lung, etc. Okay, it is a multi-factorial pathogenesis is there. Okay, this type of pathogenesis, whenever it appears, is called as a multifactorial pathogenesis, since many factors are there which are affecting the pathogenesis, and it is genetics are involving, environment is involved, immune conditions are involving, and it is an autoimmune disorder. Okay, it's a multifactorial pathogenesis. What are the genes which are predisposing the individual to rheumatoid arthritis? HLA-DR. Okay, HLA-DR, PTPN22 gene. Okay, PTPN22 and HLA-DR. This will cause the break of self-tolerance. Okay, and environmental factors like smoking, viral infection, this will cause the citrullination of cell proteins. The cell proteins are modified or citrullinated, and these both factors will stimulate the production of B cells and T cells. Okay, these T cells will start activating TH1 and TH17 activation. TH1 and TH17, as you can recall from the general path, they will cause inflammation and cytokine release will occur. There is more inflammation, more cytokine release. This B cell, what they will do, this will cause formation of anti-citrullinated peptide antibodies, since there is a citrullination of cell proteins, and the cell proteins will start being destroyed, right? And antibody to rheumatoid factors are also there, so they will affect the joints. This inflammation and cytokines will aggravate the condition. These joints will be destroyed. There will be excess proliferation of joints and damage, plus lymphocytes will be present, plus there will be lymphocytic aggregation plus proliferation, right? So you can see this diagram from Robbins textbook. Susceptibility genes, HLA or other means PTPN22. Environmental factors like infection and smoking, failure of tolerance, unregulated lymphocyte activation, enzymatic modification like citrullation of cell proteins, T and B cell responses will be there, TH1, TH17 antibodies will be there. Then This will enter the joints. This will cause release of proteagens, cytokines, proliferate and activate. Pannus formation will be there. What is pannus formation? Look at this. Some granules will be present. This proliferation actually plus your proliferation plus this lymphocytes are actually called the pannus formation. Look at this. This is the joint capsule. This is the joint capsule of the joint. This is the capsule of the joint. So look at this. There is a proliferation. There is an excess proliferation of the capsule, and with the small round blue cells, that's the lymphocytes, lymphocytic infiltration. This is called as the pannus formation. And whenever the person sleeps, there is an intertwining of the pannus. This pannus formation will cause an irregular border, and this will intertwine. And this intertwining will cause pain and stiffness, which is called the morning stiffness. The person will feel very difficult to get up in the morning, right? Look at this, what is happening. This is the normal joint. This half is the normal part up to this. So normal joint, this is synovial membrane. This is normal capsule here, capsule here, capsule here. The joint space is normal. But here look at this. There is a orangish discoloration, right? So this one is the proliferation. This is proliferated, and macrophages, plasma cell, all the inflammatory cells, basically dendritic cells, lymphocytes, these have infiltrated, and immune complexes also are there. Okay, this immune complexes also start destroying the joint. Look at this. The papillary projections are basically the pannus formations. Okay, this is the pannus form, the intertwining of the things. Okay, and if we zoom the diagram, you can see there is infiltration of small round blue cells. This is small round blue cells infiltration, right? Clinical features. What are the systemic signs of inflammation? All the signs of inflammation, all the cardinal features of inflammation like rubor, calot, tumor, dolor. Okay, all these are present in functional ESA. Then morning stiffness will be there. Okay, symmetric bilateral morning stiffness because both joints are affected. Osteoarthritis may involve one joint, but this will involve both joints, right? Smaller joints are more involved. MCP and proximal ICP, smaller joints which are they are more involved. Okay. Distal interphalangeal joints are spared. Osteoarthritis involved weight bearing joints. Okay, osteoarthritis involves the weight bearing joints, right? The hip joint, the knee joint. Okay, but this will involve mostly the small joints also. It can involve large joints, most commonly small joints. Okay, so what is the microscopy? Rheumatoid nodules in the skin. This is the rheumatoid nodule, this whole part. That is a central necrosis and surrounded by the histiocytes. Central necrosis surrounded by histiocytes are called the rheumatoid nodule. Okay, and scleritis, uveitis will be there. Leukocytic, leucoclastic vasculitis will be there. What are the complications? Look at this. Swan neck deformity of the fingers. You can see here in this, X-ray findings. Swan neck deformity. Look at this swan neck deformity. It appears like the beak of a swan. Okay, you must have read about this in anatomy. The pannus will stick and will cause fibrous ankylosis. And this fibrous ankylosis can lead to deformities like swan neck, or it can cause bony erosion. It can erode the bone also. It can erode the bone, most commonly seen, and there may be bony ankylosis also. Serology. Okay, anti-CCP antibodies. Okay, anti-CCP antibodies and rheumatoid factor. Let's come to another important part, that is the bone tumor. It is a bit confusing part, but I guess we can do this. Let's come to classification first. Bone forming tumors, cartilage forming tumors, of unknown origin, and tumors which are stimulating in nature, that is stimulating tumors, or tumors of others. You can classify this as others. Okay, this is the Robbins classification. Okay, cartilage forming, bone forming, and tumors of unknown origin. Understood? Okay, so bone forming tumors, we have osteosarcoma and osteoma. Okay, osteoid osteoma and osteosarcoma. Then cartilage forming tumors, we have chondroma, osteochondroma, and chondrosarcoma. Osteochondroma, and osteosarcoma. Of unknown origin, we have Ewing sarcoma, giant cell tumor, aneurysmal bone cyst. Okay, Ewing sarcoma, giant cell tumor, and aneurysmal bone cyst. Stimulating tumors, we have fibrocortical defect and fibrous dysplasia. But we have to read this osteosarcoma. Osteoma is not much given detail. Osteosarcoma, then osteochondroma, chondrosarcoma, Ewing's, giant cell, aneurysmal bone cyst in details. Okay, have to read this. Okay, so bone tumors, primary tumors of the bone are very rare. But the metastasis and hematopoietic tumors are more common. The metastasis is more common in bone. Okay, What are the symptoms? Basically there will be swelling and pathological fractures will be there, not physiological fractures, pathological fractures. What is the diagnosis? You can diagnose by radiology, that is x-ray. Okay, it is more important since it is a non-invasive procedure. Or you can do your Jamsedi needles biopsy. Jamsedi needle biopsy, you can use this kind of needle. This kind of needle is asked in spotters, that's why I put the diagram here. This is called as a Jamsedi needle. This Jamsedi needle biopsy, J needle biopsy, is done for the diagnosis. So the classification. Okay, look at this. So cartilage forming tumors, if we start with, let's start with bone forming first. So bone forming tumors, it can be benign, okay, or it can be malignant. So benign tumor are two in number: osteoid osteoma and osteoblastoma. Osteoid osteoma and osteoblastoma. Malignant one is the osteosarcoma. Okay, and this osteoblastoma affects the vertebral column more, but this osteoid osteoma and osteosarcoma, this will affect the metaphysis of long bones, okay, like femur. Understood? And talking about cartilage forming tumors, so we have osteochondroma and chondroma, which is the benign type, and chondrosarcoma is the malignant type. Okay, you can see wherever there is a sarcoma, here is a sarcoma, here is a sarcoma, they are the malignant types, right? So benign type is osteochondroma and chondroma, and malignant type is osteosarcoma. Osteochondroma affects the metaphysis of long bones, chondroma affects small bones of hands and feet, and chondrosarcoma affects the pelvis and the shoulders. Don't need to remember that much. When I will discuss the tumors in detail, we'll read about that. And tumors of unknown origin, we have giant cell tumor. Okay, giant cell tumor that will affect the epiphysis of long bones. Aneurysmal bone cyst, you can remember like this. Giant means epiphysis of long bones, giant, long, same type of words. Aneurysmal bone cyst, which will affect proximal tibia, distal femur and vertebrae. And malignant counterpart, we have Ewing sarcoma, that will affect the diaphysis of long bones. Okay, Ewing sarcoma will affect the diaphysis of long bones. Done. If we are familiar with this table from Robbins, let's move ahead and discuss based on classification of bone tumors based on location. On what location it is present. So diaphysis, metaphysis, epiphysis. If you draw this diagram in your exam, then it is a very good impression will be there. Okay, let's talk about diaphysis first. Diaphysis, what are the tumors from here? So majorly hematoid tumor, like hematogenous tumor, like hematolymphoid tumors, all the hematolymphoid tumors, all the metastasis. Ewing sarcoma, from that diaphysis, you can see Ewing sarcoma, diaphysis of long bones here we discussed. So Ewing sarcoma and fibrous dysphasia. Okay, fibrous dysphasia, fibrocortical defect, this all. Fibrous dysplasia and fibrocortical defect, stimulating tumors basically appear in the diaphysis, right? Okay, then metaphysis, what are the tumors? We have osteosarcoma, osteoma, chondrosarcoma and aneurysmal bone cyst. Okay, osteosarcoma, osteoma, chondrosarcoma and aneurysmal bone cyst, all these tumors. Okay, from the junction one tumor is there, from the junction of epiphysis and metaphysis, here a tumor originates, and this is osteochondroma, and only two tumors from the epiphysis. Okay, two tumors, giant cell tumor and chondroblastoma, done. So you can observe that majorly the malignant tumors appear from the metaphysis itself. The malignant tumors like osteosarcoma and chondrosarcoma, okay, these appear from the metaphysis itself. Let's talk about osteosarcoma first. That's a malignant bone tumor. Most common primary malignant bone tumor is osteosarcoma. Okay, what are the age groups affected? Primary osteosarcoma, or maybe secondary osteosarcoma. Primary osteosarcoma 25% affect in the first and second decade of life. Secondary osteosarcoma is secondary to disorders like Paget's disease of bone or disorders like irradiation. Okay, and it appears late in life, that is 5th to 6th decade of life. Since it is secondary, okay, secondary means it generally have a late presentation. What are the genetics? It may be due to RB gene mutation, retinoblastoma gene mutation, or it may be due to P53 loss, TP53 loss. Wherever there is P53 loss, just make sure to write it is worse prognosis and chemotherapy will be resistant. Okay, these tumors are difficult to treat, which are associated with T53 loss. Or there may be MDM2 gene mutation. Location is around the knee joint. Radiology, another characteristic finding are the Codman triangle and sunburst appearance, which are seen in the osteosarcoma. So look at this. Here you have the periosteum present. This periosteum. This is the periosteum, right? This is the periosteum. So there is a tumor here. So the periosteum will be stretched like this, and will the stretching of the periosteum will appear like to be a triangle. This appears to be a triangle. This appears to be a triangle, and this triangle is called as the Codman's triangle. That is lifted periosteum. This lifted periosteum is called as the Codman's triangle. Understood? Okay. Then this tumor may invade the soft tissues. This tumor, when it invades the soft tissues, okay, due to invasion, there may be a calcification of soft tissues. Okay, which type of calcification will be present? Which type? Dystrophic calcification. Yes, because it is due to an injury. So there is a calcification of soft tissues that will be occurring, and this appears in the, you can see in the X-ray as this type of appearance, a burst type of appearance, like sun rays are coming, right? Sun rays are coming. This is called as a sunburst appearance. Sunburst appearance. Okay, this appears like a sunburst appearance. Understood? Okay. So this is the Codman's triangle. You can see this is the Codman's triangle present. This is the Codman's triangle. Yeah. Okay. In the X-ray. Let's move on to the gross findings. Okay, what are the gross findings here? Look at this. Look at this gross. There is an invasion here. The tumor is present over here. Due to this, the periosteum is stretched much. Okay, look at this. There is an invasion of soft tissues as well. Look at this. Okay, this is a tibia. And what are the that microscopy? Okay, microscopy. This is a neoplastic or malignant osteoid will be present. Okay, there will be the 4 features of dysplasia. You know the 4 features of dysplasia, right? I guess you all know that what are the 4 features. That is the loss of polarity, the presence of mitotic figures, and the atypical mitosis, then invasion and all. Okay, then neoplastic osteoid or malignant osteoid is present. That means that the normal osteoid is that whenever there is a bone, it is surrounded by osteoblasts. Okay, it's surrounded by osteoblasts. You must have seen in the Haversian canal itself. But here, there is, in carcinoma, there is no osteoblastic rim. Okay, there is no osteoblastic rim, so it is not surrounded by any osteoblasts. You can see, and here, if the bone is present, you can see there is no osteoblast associated with this bone. Okay, and here mitotic figures may be seen, which is a characteristic feature of dysplasia. Let's move on to the next tumor, that is Ewing sarcoma. Cell of origin is undifferentiated mesenchyme. This is important. Okay, the cell of origin is an undifferentiated mesenchyme. Understood? Age, first to second decade of life. Any other tumor first to second decade of life? Yes, primary osteosarcoma, first to second decade of life. Secondary was 5th to 6th decade. Okay, you have to read like this to memorize the previous things also. Can arise from the bone or the soft tissue. It can arise from the bone or the soft tissue. Radiology is this characteristic moth-eaten appearance or the onion peel appearance. Very important. Okay, onion peel, you have seen the onion peel. It appears like layer. Okay, it appears like this. So look at this. Look at this part. Focus on this part. Okay, look at this part. So it appears like a onion skill appearance, right? Can you understand? Yes. Pathogenesis, 90% cases is due to translocation 1122. The chromosome number 11 and chromosome number 22. This chromosome number 11 has EWSR, that is Ewing sarcoma 1 gene. This chromosome number 22 has FLI gene. And this translocation will cause overactivation of FLI. Okay, overactivation of FLI, and it will lead to the tumor. What are the pathogenesis in the osteosarcoma? RB gene, T53 and MDM2 gene mutation. What is the pathogenesis in Ewing sarcoma? Pathogenesis is simple, T1122. Okay. Microscopy, small round blue cells. Again, small round blue cells are present here. Look at this, small round blue cells. Perivascular pseudorosettes, important. Okay, remember we talked perivascular pseudorosettes are present in the Ewing sarcoma. Remember? Yes, we talked a little bit before. Perivascular pseudorosettes are present, and this small round blue cells will have stored glycogen. So PAS positive, PAS10, you know, PAS10 is positive for glycogen, right? It is PAS positive. So this slide is of Ewing sarcoma. Then immunohistochemistry, CD99 positive, FLI positive, and fish FISH is the genetic marker, fluorescence in situ hybridization. So FISH will be also positive here. Understood? Let's come to the giant cell tumor. So giant cell tumor, older term was osteoclastoma, but it is a misnomer since there is no involvement of osteoclasts. Okay, the precursor, the cell of origin is osteoblast actually, but previously it was thought to that of it is originating from osteoclast. That's why it was called osteoclastoma, but it is now a misnomer. We know now the cell of origin is primitive osteoblast precursor. What is the cell of origin in Ewing sarcoma? Remember, undifferentiated mesenchyme. Okay, the cell was undifferentiated mesenchyme. Where was that? Undifferentiated mesenchyme. I guess you are remembering the things along with the class. Yes. Okay, so I was talking about giant cell tumor. Age is 20 to 40 years, that is second to fourth decade of life. Seen around the knee joint again, like osteosarcoma. Seen in epiphysis. Okay, epiphysis. Let's revise the epiphyseal tumors again. What are the tumors in epiphysis? Two important tumors, chondroblastoma and giant cell tumor. Chondroblastoma and giant cell tumor. What is the gross? Look at this. The gross cyst will be present. It will not invade outside the periosteum. Okay, it will not go outside the periosteum. A meshwork will be present. In the leftover bone, there is a cavity in the leftover bone. Okay, due to which the bone will become porous and will be associated with hemorrhage. Look at this. Look at this radiological finding here. So here there will be the association presence of hemorrhage. The bone is hollow. So you can just as observe that there can be a chance of pathological fractures. Any bone tumor can have a chance of pathological fracture, but this has more chance due to this cavity area. Okay, so leftover bone, hemorrhagic areas over the leftover bone is a characteristic finding of giant cell tumor. It is very aggressive tumor. It is a benign tumor, or it can rarely become malignant also. What is microscopy? Non-neoplastic osteoclastic giant cell. Giant cell tumor means there will be giant cell. Okay, you know the giant cells. Okay, you know the giant cells from general path. A cell with multiple nuclei is called as a giant cell. How it is formed? The Th2 activation of the macrophages, due to which the macrophages will start to aggregate. Okay, and neoplastic mononuclear stromal cells. These are the stromal cells which are associated with this. Okay. Next comes the Paget's disease. Remember, Paget's disease are two, in bone and in breast also. So Paget's disease this is the Paget's disease of bone, right? It is totally different from that of breast parenchyma. Don't confuse that. It is also called as osteitis deformans. Osteitis deformans. Okay, osteitis deformans. There is a deformation. There is a deformation of bone. There is a deformation of face also, where we'll see leonine facies. This is the leonine facies. You can see. We'll come to here. Okay, leonine facies. Let's talk about that first. How the different pathogenesis occurs. This is a normal bone. Let's assume this is a normal bone. So what happens is that the resorption occurs. There is a resorption. This is removed by osteoclast. This bone is eaten away by the osteoclasts. Okay, and this osteoblasts are basically filled over here. The osteoblasts filled over here. So there is a loss of coordination between the resorption and desorption. Okay, there is a loss of coordination between, you can write between resorption and desorption of bone. So there is a loss of coordination between the resorption and the desorption of the bone. Three phases. Paget's disease is three phases. Initial osteolytic phase, due to which in which the bone is basically broken down by osteoclast. Mixed lytic sclerotic phase, in which the osteoclast and osteoblast both are in the action, and then burnt out osteosclerotic phase. Initial osteolytic, mixed lytic sclerotic, and burnt out osteosclerotic phase. What is the proposed pathogenesis? There is no definite pathogenesis. So we believe that it may be of a viral etiology like paramyxovirus, or it may be due to mutation of the rank gene, that is a gain of function mutation. Okay, it is a proto-oncogene. So rank ligand pathway is there, and it may be due to osteoprotegerin gene. Okay, loss of function mutation of the tumor suppressor gene, that is the osteoprotegerin gene. Okay, associated rank gene or osteoprotegerin gene. What is the pathogenesis in what is the genetic factors which were causing Ewing sarcoma? Yes, I can hear you. T1122, right? Symptoms appear in 4th to 5th decade of life. It is initially asymptomatic, then face changes will occur. Face will undergo deformities. A heavy skull will be there, a heavy skull and drooping of head, a heavy skull and drooping of head. This is called the leonine faces. This you can see the bony, the face appears bony. This is bones. Okay, these are the facial bones which are proliferated like this. Okay, lion like face. Increased bone formation, so pancytopenia will be occurring. Okay, and decreased lumen of bone foramina. Due to excessive proliferation, the lumen of the skull, foraminas of the skull, okay, the skull foraminas will let's say this is a foramina. This will due to excessive proliferation, this will cause there will be calcification associated with it. Okay, calcification will occur, and this will lead to the nerve entrapment. If this is the skeletal foramina and the nerve was going here like this, some nerves in the cross sectional view, and there is an excessive proliferation, so there is a nerve entrapment. Okay, the cerebral and lumbar nerves will be compressed. Look at this, cerebral nerve palsies will occur, and cervical and lumbar nerves can be compressed. Cervical and lumbar nerves can be compressed, and there may be pathological fractures as well. There may be pathological fractures as well. Okay, pathological fractures as well. Okay, it is dense but it is brittle also. Okay, it is not like it is very consolidated, right? It is brittle also. Look at this, the bone marrow. If you do the bone marrow biopsy, then there is no space left in the bone marrow. There is no space left in the bone marrow because there is increased bone formation, pancytopenia will be occurring. Okay, and this is a characteristic the appearance. This appears like a mosaic, so it is called as a mosaic pattern of the bone. So it appears like a mosaic pattern of the bone. Look at this mosaic pattern of the bone. This is seen in the Paget's disease. So that's about the bone tumors. Let's move to the next topic of pathology. Then let's come to the meningitis. So in CNS, people also ask you meningitis sometimes. Okay, and but it is not much of diagnostic importance, or in pathology. Of course, it is important, but it is not much taught in at parts of that in pathologies. Okay, let's discuss this. Okay, we will not leave any part. So what are the features, what are the types of meningitis? Three types of meningitis are there. Meningitis is the inflammation of the meninges, and the classical feature is the headache. So we have something called the acute pyogenic or bacterial meningitis. We may have a acute lymphocytic or viral meningitis, or you may have a chronic or tuberculous meningitis. Chronic or tuberculous meningitis. Okay, so three types of meningitis are there. And what are the naked eye appearance in all of this? So look at this. What is the normal appearance of the normal CSF? Okay, this is the normal CSF. Just a minute. So talking about normal CSF is clear and colorless. Normal CSF is clear and colorless, but in meningitis, in acute pyogenic meningitis, due to presence of bacteremia, cloudy or frankly purulent, that is pus containing. Okay, meningitis. So cloudy or frankly purulent naked eye appearance of the CSF. Okay, this is the CSF. Naked eye appearance is being talked of CSF. Okay, and in viral meningitis, it may be clear or slightly turbid. Remember, so it is mostly clear, you can consider. And in chronic tuberculous meningitis, we have a cog web, that is fibrin coagulum on standing, a cog web appearance. Importantly, if this fibrin word is not given, don't ever jump to the diagnosis of chronic tuberculous meningitis, chronic or tuberculous meningitis. Okay, then CSF pressure. Normal CSF pressure is 60 to 150 mm of water. Okay, 60 to 150 mm of water. In bacterial meningitis, it is elevated, 180, and in viral meningitis, it again more elevated, above 250. Okay, and chronic tuberculous meningitis, it is even more elevated, above 300. Okay, above 300. These statements are important: 180, 250 and 300. Okay, let's talk about cells. So we have 0 to 4 lymphocytes per milliliter here. Okay, 0 to 4 lymphocytes per milliliter here. Here in acute bacterial meningitis, we have 100 to 1000 neutrophils. 100 to 1000 neutrophils. You know that neutrophils are effective against the bacteria, so 100 to 1000 neutrophils are there. In viral meningitis, we have 10 to 100 lymphocytes. Okay, 10 to 100 lymphocytes. Okay, neutrophils are absent, lymphocytes are there. And here also there is a 100 to 1000 lymphocytes, important. Okay, in both of this we have the lymphocyte presence. Okay, this, in both of this the lymphocyte is present, but here we have the neutrophils which is present. Here the neutrophil is present, here lymphocyte and here lymphocyte. Understood? This is important, remember. And normal range you have to know. Glucose 50 to 80 milligram per deciliter is the normal. 50 to 80 milligram per deciliter is the normal, and in acute pyogenic it is markedly reduced. It is reduced. Okay, the glucose is reduced. It is normal in viral. This is important. It is normal in viral. Okay, whenever there is a decline on glucose, okay, more decline is seen in bacterial and tuberculous also. Decline is seen in tuberculous also. It is also reduced. Protein 15 to 45 milligram per deciliter protein is normal. 15 to 45 milligram per deciliter. It is elevated. It is elevated in bacterial and tuberculous. Okay, so glucose and proteins are the things which are there. So there is a decline in glucose. Okay, there is a decline in glucose and the increase in protein in this bacterial and tuberculous meningitis, right? If we do a bacteriology, that is the work of microbiology department, okay, the bacteriology, so it will be normally it is sterile, no bacteria are present in the CSF. But here in acute pyogenic you can see the bacteria. You can do the gram stain also, you can see the bacteria, and dark ground microscopy is also done in some cases. Okay, in viral there will be sterile important, there is sterile important. And in here the tuberculous meningitis, tubercle bacilli is present. Tubercle bacilli is present, that is Mycobacterium tuberculosis. Okay, so that was about a important discussion on meningitis. Let's move on to our next topic. Let's move on to the skin pathology, where we have to discuss the nevus and melanomas. Okay, two important topics. So look at this. This is the epidermis and this is the normal dermis. Okay, this is a dermis layer from where the dermis starts from here. Okay, and this is the stratum basale, that is the most basal layer of the epidermis. Okay, most basal layer of the epidermis is stratum basale, where melanocytes are generally present. And in these conditions, nevus and melanomas, will see that this melanocytes will lose their polarity and will be deposited here and there due to his a dark spot is formed in your skin, right? Look at this part. So I guess you all know the layers of the epidermis. So this is the uppermost layer, that is stratum corneum. This is stratum lucidum. The stratum lucidum is not present everywhere, but is present in the thick skin only. Thick skin means the palm and soles. This is the stratum granulosum, where granular inclusions are there. Stratum granulosum here. Okay, this is the stratum spinosum, where spine-like processes you can see. Okay, and here is the stratum basale, and stratum basale is the germinativum layer. And here the melanocytes, you can see this melanocytes with this dendritic inclusions. Okay, these melanocytes are present over here, right? Nevus means commonly called as the moles. It is the most common benign tumor of the epidermis. You can see this is the nevus in the skin, this is the mole on the skin, and this is also a tumor. Okay, it is the most common benign tumor of the epidermis. What's the pathogenesis of the nevus? So here let's assume this is the normal skin, and in the stratum basale layer we have the melanocyte present. There is a RAS mutation associated with this. RAS mutation, RAS is the proto-oncogene. Due to this RAS mutation, there is a proliferation of melanocytes. The melanocytes will start proliferating here. This proliferation has occurred, and this is called as a junctional nevi. Junctional nevi means proliferation is occurring at the dermo-epidermal junction, the junction between the dermis. So you can see here is the dermis. Okay, this is the dermis and this is the epidermis. Okay, so you can say proliferation has occurred in the dermo-epidermal junction, that is junctional nevi. Understood? And after this, junctional nevi will grow downward. Okay, this junctional nevi starts growing downward, and you will see that some epidermal component of this junctional nevi is present and some dermal components are also present. Means there is epidermal proliferation. The epidermal part is present over here. It was already present, but it starts growing downwards. So it is now half. Okay, it is now half. Some epidermal portion and dermal portions are present. So junctional component plus some dermal components. Okay, this is called as a compound nevus. Okay, compound nevus, and it grows more downwards. Then this epidermal portion now starts disappearing. This whole part comes to the dermis. it cuts up the junctional component, and here it comes to the dermis. And this is now called as the intradermal nevi. Okay, this then problem what occurs is that there is a phenomenon of RAS induced senescence. And due to this nerve cell now mature into this nevus cell mature into nerve cell. Okay, this nevus cell mature into nerve cell, which is called the neurotization of the nevi, and this will prevent the progress into a melanoma. So basically this phenomenon of RAS induced senescence is preventing the nevi to progress into a melanoma. And if there is a defect in this RAS induced senescence, then the nevus will progress into a melanoma and there will be no neurotization. Understood? Look at this diagram of Robbins. Very beautiful diagram. You can see in normal skin only scattered melanocytes are present. Look at this cells which are yellowish oranges in color. Okay, this is present only in the basal layer. Okay, normally 1, 2, 3, 4. Okay, 4 cells. But look at this here. Look at this. There is a proliferation. Okay, how many cells are there now? 5, and here 4, 9 cells. Okay, there is a proliferation. This is a which type of nevus? A junctional nevus, right? Because this is the epidermis. This is the epidermis, and this is the dermis. Okay, and it is present in the proliferation is occurring in the which part? The junction, right? So it is a junctional nevi. And here some epidermal components are there also, and dermal components are there also. So which type of nevi is that? Compound nevi. Here what happens? Here there is an intradermal nevi. You can see all the parts are in dermis, and here there is a neurotization which is occurring, and this will prevent it from due to the progression. It will prevent the progression to the melanoma. Okay. Let's now move to the melanoma. Let's say this the mechanism of this RAS induced senescence has cut off or gone. So we will see melanoma. Okay, we'll see the pathogenesis of melanoma. We'll see the phases of melanoma, and what are the things we have to know in melanoma. What are the clinical things? Okay, so melanoma has multiple origins. Okay, etiology: sun exposure is the main etiology, where the UV rays will cause mutation, and this mutation will make this RAS induced senescence system defunctional. Okay, it is a multi-step pathogenesis. In light skin individual, due to mold, due to any cause, may form a dysplastic nevi, and this dysplastic nevi is the precursor of melanoma. What is the pathogenesis? So let's assume we have a nevus form here. Nevus is formed due to RAS mutation. Okay, we saw earlier, right? UV rays, we got exposure to UV rays, acquires some new mutations like P16 mutations in gene CDKN2A. Okay, CDKN2A gene, very important. P16 mutation in gene CDKN2A, or P10 mutation, that is P10 loss, or BRAF V600E mutation. Okay, or BRAF V600E mutation. Due to any of this mutation, due to P16 gene CDKN21 and 2A, or P10 loss, or BRAF V600E, okay, this RAS will get activated by this RAF pathway or PI3K pathway. Okay, this RAF pathway or this PI3K pathway. This RAS is getting activated. Okay, and this P16 actually, this P16 mutation, this P16 is inhibiting the RAF pathway. Okay, RAF pathway, due to which the RAS gets inactivated. And this P10 was inhibiting the P13K pathway. But now what happens is a P16 mutation. So RAS will be more active. Okay, this RAS will be more active, and this RAS induced senescence will be defective, right? So there is a formation of dysplastic nevi, there is a disordered growth, and due to telomerase activation and other factor which is causing telomerase activation, it progresses to melanoma. Okay, so here what happens? In the horizontal phase, this melanocyte, there are some of the phases of melanoma, right? And based on these phases, we have the subtypes of melanoma as well. Okay, we have the horizontal phase melanoma, and the vertical growth phase of melanoma, and a radial growth phase of melanoma. Understood? So let's see what are the phases. Horizontal or radial growth phase, which means that the tumor cells will spread horizontally along the epidermis. This tumor cells, look at this, these have spread horizontally along the epidermis. Based on this, we have subtypes like lentigo maligna. Okay, lentigo maligna, which is seen in elderly and it takes years, very slowly growing melanoma, lentigo maligna. We have superficial spreading melanoma, which is the most common in sun exposed individuals, mainly in fair skinned individuals, not light skinned individuals. And we have something called as an acral melanoma, right? Lentigo maligna, then superficial spreading melanoma, and acral melanoma. This acral melanoma or lentiginous melanoma is seen in non-exposed areas of the skin, non-exposed areas of the skin, which is not usually exposed. Then we have a vertical growth phase. Vertical growth phase, this cells will grow downwards, increased spread of tumor and metastasis will occur. Here nodular melanoma is formed. Nodular melanoma, you can see a nodule is formed like this on the skin. A nodule is formed like this on the skin. Okay, this is a nodular melanoma. So it is a melanocytic nevus and relatively small, symmetric and uniformly pigmented. The gross appearance is small, symmetric and uniformly pigmented. Okay, and this is the thing which is there. And another thing, we have a radial growth phase also, where the cells are growing radially also. The cells are growing, you can see radially. This type of growth is also seen. Okay, and this is the vertical growth phase. So there are similar diagrams. Okay, so what is the clinical? And this is a mole and this is a melanoma. So melanoma has a color variation. You can see there is a difference in color. Okay, color variation is there, and the clinical the clinical features of melanoma can be memorized. We call it an ABCDE scheme. ABCDE scheme, which is often asked by examiners. So A is asymmetrical. It is asymmetrical. The borders are irregular. You can see the borders are irregular like this. Okay, there is a color variation. We saw there is a color variation. Diameter more than 0.6 centimeter. The diameter more than 0.6 centimeter, and there is a evolution. There is a evolution. Evolution means that it can progress to any other conditions of the skin. Microscopy, highly pleomorphic, and pigments are present. Mostly pigments are present in the dermis, right? Immunohistochemistry, S100 sensitive. S100 is positive, so it is a sensitive test. And HMB45 or Melan A, you can remember this. Melan A is S100 and Melan A, you just remember this both. Okay, S100 was also positive in DEX. S100 was also positive in DEX. Yes, we talked about the CNS tumors, schwannoma. Okay, it is also present in schwannoma. What is the grading of melanoma is done by old was Clark and Breslow system, and now we have the TNM strain. TNM grading is the most common grading system which we nowadays follow. It's also present in the breast and the lung tumors are also TNM graded. Many tumors are there. What is the prognosis? It has a good prognosis. It has a good prognosis. Okay, and what are the points which are there in good prognosis? If the tumor is less than 1.7 mm depth of invasion, the depth of invasion, right? Less than 1.7 mm depth of invasion, that's a good prognosis. Few mitosis is a good prognosis, and if there is no regression. Okay, if there is no regression, because if it regresses, remember we have a bad prognosis associated with it. Okay, if there is regression, then there is bad prognosis, because it will arise back even with more force. Okay, if there is regression, then it will arise back with even more force. Done. So that completes our nevus and melanoma. Let's move on to the next topic. Okay, so here I have the Robbins, and we'll talk about some of the carcinomas of the skin. And first, let's talk about squamous cell carcinoma. So squamous cell carcinoma is the most common tumor that typically arises on the sun-exposed skin in older adults. Okay, and this squamous cell carcinoma is caused by the pathogenesis is UV light exposure. Okay, and the patient with xeroderma pigmentosum have a increased incidence of this squamous cell carcinoma, and some of the genetics associated are TP53. Okay, and activating mutations in RAS and loss of function mutation in Notch receptors. Okay, these three are the things which are there. And squamous cell carcinomas are gross is the sharply defined red scaling plaques. Okay, and they show variable degrees of differentiation. Okay, and they have the cells having highly anaplastic cells with foci of necrosis and a single cell keratinization, or called as the disc keratosis. So look at this. This is a squamous cell carcinoma, and it is present behind the ear, the auricle of the ear. Okay, and this tumor invades the dermal soft tissue and atypical squamous cells exhibiting acantholysis. Okay, and look at this. They are small and resectable. They often are discovered while they are small and resectable. They can be resected. Okay, less than 1% will metastasize to regional lymph nodes, and the likelihood of metastasis is often very rare. And squamous cell carcinomas arising at internal sites, basically like oropharynx, lung, esophagus, anus, are generally invasive and aggressive. But in skin, they go unrecognized and are not much of importance, right? So that was about squamous cell carcinoma. And now let's talk about a basal cell carcinoma. This is also important from your pathology point of view. So basal cell carcinoma is a slow growing cancer that rarely metastasizes. Okay, and what is the pathogenesis? Important. The pathogenesis, the molecular hallmark of basal cell carcinoma is the loss of function mutation in PTCH1, a tumor suppressor gene that negatively regulates hedgehog signaling pathway. Okay, just remember these lines. You have the hedgehog pathway. We don't go into detail. The smooth was there and the rough is there, and many things are there. Hedgehog pathway, if I talk about it, will be another lecture. Okay, so the mutation, the main thing, important thing is the mutation in the PTCH1, and PTCH1 is what type of gene? It is a tumor suppressor gene, and it is a negative regulator of which pathway? Negative regulator of hedgehog pathway. Okay, understood? So this is the main mechanism of action, right? The pathogenesis, I guess. Okay, and here a Gorlin, it may be associated with Gorlin syndrome. What is Gorlin syndrome? Gorlin syndrome is an autosomal dominant disorder caused by inherited defect in PTCH1. Okay, this is an inherited defect in PTCH1, so it may be associated with Gorlin syndrome as well, and it may be caused due to mutation in TP53 also, which is common in both familial and sporadic tumors. Okay, so this manifests Pearly papules. Pearly papules. You can see this is a prototypic Pearly papule. Okay, a smooth surface papule with telangiectatic vessels. Telangiectatic vessels means prominent dilated subepidermal blood vessel is called as a telangiectasia. Telangiectasia. So prominent dilated subepidermal blood vessels is called as a telangiectasia. So it manifests as Pearly papules in the gross. This is a gross finding. Okay, and first one, and the second thing is the telangiectasia. Okay, and microscopically they arise from the epidermis or the follicular epithelium. Okay, so two common patterns which may be seen in the multifocal superficial growth or nodular lesions. Multifocal superficial growth or nodular lesions. Okay, in a island of variably basophilic cells with hyperchromatic nuclei are also seen. Okay, and a palisading pattern may be present. A palisading pattern may be present. Look at this. Look at this. Look at this. Tumors consist of nests of basaloid cells. So these have a nests of basaloid cells. You can write over here that the microscopy is the nests of basaloid cells. These are the nests of basaloid cells. Okay, and these basaloid cells have a hyperchromatic scant cytoplasm. These basaloid cells have a feature of scant cytoplasm. Scant cytoplasm with hyperchromatic nuclei. This is the characteristic feature of something called the basaloid cells. So the presence of basaloid cells in the layer also. Okay, so this is a scant cytoplasm, small hyperchromatic nuclei, and we have a pattern, this type of pattern, and here this type of pattern is called as a palisading pattern. This is a palisading pattern. Okay, so this is the gross finding and the that. Okay, we talked about melanocytic nevi, and we saw this diagram and all. Okay, that completes our skin in toto. So in skin we discussed the important things, that is our mole or the nevus. We call it nevus in pathologist term, mole, or then we talked about our melanoma, and the squamous cell carcinoma of skin and the basal cell carcinoma. Okay, these four things are important in the skin. Now let's come to the next chapter. Okay, let's move to the next chapter. So after completing our CNS tumors, we completed the bone tumors and we completed our skin. Okay, CNS, bone and skin, three chapters we have completed, and meningitis also have discussed. And now we are into our hepatobiliary pathology. Okay, hepatobiliary system is the important topic, and here we have to majorly discuss two things, that is the jaundice and its associated syndromes. Okay, jaundice, and then we'll talk about some of the hepatitis. Okay, jaundice and hepatitis, and alcoholic fatty liver disease. Okay, alcoholic liver disease and cirrhosis liver, we'll talk about all this. Okay, hepatobiliary pathology, and that will complete our hepatobiliary pathology in total. So liver histology, so we have some hexagonal lobules. This is a normal histology of the liver. Okay, first we will talk about normal histology. So we have this hexagonal lobules present over here, and between the hexagonal lobules we have what are the things? Portal triad. What are the consistence of portal triad? Portal vein, hepatic artery, and biliary radical. That is a bile duct. We tell it bile duct, but biliary radical is a better term. Portal vein, hepatic artery, and a biliary radical, right? What is the major blood supply of the liver? Blood supply is portal vein, the superior mesenteric vein and the splenic vein. They join together to form the portal vein. You must have read this in anatomy. Look at this. This is a hexagonal lobule, and these are the zones. And the correct categorization of zones, I will tell you how it is categorized. Just now don't focus on this. Okay, look at this. These are the hexagonal lobules, and this is the central vein which is present. Central vein. This is central vein, and between this hexagonal lobules, between the intersecting point of the hexagonal lobules, we have something called as a portal triad. Portal triad, remember. Okay, so what are the functions of liver? The function of liver are metabolic functions and detoxification functions. Okay, and this thing is the mechanism of liver. Metabolic and detoxification functions you all know. The metabolism occurs, all the fat protein metabolism you can write from yourself, right? Okay, so this is the working of the liver. Look how it is arranged. Okay, this is the central vein. Okay, and these are the cords of cells which are arranged. These are cords of the hepatocytes which are arranged, and this is the portal triad. This is the portal triad. This is hepatic artery. This is HPB. That's the portal vein and biliary radicals. Okay, so what happens is that between the hepatocytes, from the GIT and spleen, GIT and spleen, blood flows between the hepatocytes. Blood flows between the hepatocytes, in between the columns of hepatocytes in this direction, and drain into the central vein. The central vein drains into inferior vena cava. Okay, this is central vein drains into inferior vena cava. Understood? And what about the bile? Okay, what about the bile? So this bile is collected from this blood. These are the sinusoids, and from sinusoids the fluid leaks out. Okay, these are the capillaries, right? Blood sinusoids. The fluid leaks out, and the fluid leaks out and goes via this biliary sinuses. These are the sinuses. Okay, these are the sinuses between the hepatocytes. The sinuses between the adjacent hepatocytes, small sinuses, which are taking this bile from here and draining it into biliary radicals. This drains into bile duct and the common bile duct. Okay, all the bile ducts, and this go to the common bile duct. This goes to the ampulla vater, and it goes to the second part of duodenum. This sinusoids are called as the bile canaliculi. Okay, which connects the two hepatocytes. I told you it is between the two adjacent hepatocytes, right? So we can observe that the flow of blood and the flow of bile occurs in an opposite fashion. Okay, the flow of blood and the flow of bile occurs in an opposite fashion. Remember, okay. Then opposite direction, which is called the counter current flow. Understood? Okay, let's move on to the zones of the liver. What are the zones of the liver and how it is categorized? We saw here in the sinusoid, zone 1, 2 and 3 are present. Okay, zone 1, 2 and 3 are present. So now we'll talk about the zones in detail. Okay, look at this. Central vein is here, and the portal triad is here. Central vein is here and the portal triad is here. So the area near the central vein is called the zone 3, then zone 2, then zone 1. Okay, this zone 3 is called the pericentral because it is near the central vein. This is transitional zone and this is periportal zone. Pericentral, transitional, periportal. You can write over here. This is pericentral zone. This is transitional zone. And this is periportal since it is near the portal triad. Understood? These are the zones of the liver. And based on this, what is the metabolism which is occurring? So which zone is receiving the maximum oxygen? Which zone receives the maximum oxygen? Here, zone 1. Okay, which zone receives the which zone is responsible for the maximum metabolism? Zone 3. Remember, zone 3. Understood? So here maximum metabolism occurs like glycolysis, lipogenesis, xenobiotic metabolisms. Okay, glycolysis, lipogenesis and xenobiotic metabolism. In transitional zone, the mixture of functions will occur. So what are the functions of zone 1? Oxidative metabolism, gluconeogenesis and ureagenesis. Oxidative metabolism, gluconeogenesis and ureagenesis. Okay, and all these functions, this mixture of functions is occurring in the transitional zone. So you can here see another diagram. Zone 1, this is the zone 1, this is the whole zone 1. Okay, and this is a zone 2 transitional zone, the zone 3 which is the pericentral zone and nearer to the central vein. So this is the central vein and this is the portal vein or the portal triad. Okay, and these are the zones categorization. So as we move from the portal vein to the central vein, there is a decreased vascularity. So there is an increased vascularity here, which is evident from the fact that it gets the maximum oxygen. Okay, it gets the maximum oxygen, right? So here we have the maximum vascularity and here we have the least vascularity. Okay, so you can just write this zone 1 will have the max vascularity and this zone 3 will have the least vascularity. Understood? Then let's talk about the bilirubin metabolism, and this bilirubin metabolism will be important since we'll discuss the jaundice. Okay, we'll discuss all the causes of jaundice, all the syndromes of jaundice are important here. Jaundice as a whole is given in many chapters, but the syndromes of jaundice are important from the pathology point of view, like the Crigler-Najjar syndrome, the Gilbert syndrome, Rotor syndrome and all. Okay, so let's first discuss the bilirubin metabolism. So let's discuss the bilirubin metabolism. So here we have a RBC, and RBCs, you know, that go to the spleen for destruction and broken down by littoral cells. Littoral cells basically are splenic macrophages. Okay, so splenic macrophages have different names in different areas, like we have our Langerhans cells, we have our something called as a, you know, many names are there, dust cells. Okay, and Kupffer cells in liver, many cells there. So splenic macrophages, due to which there is a release of bilirubin which is unconjugated, and it bilirubin combines with albumin, and this process is not called conjugation. This bilirubin, unconjugated bilirubin, when it binds with albumin, this process is not called conjugation. This albumin is basically a carrier which takes the bilirubin to the liver. Okay, understood? And in the liver, the albumin dissociates. And this bilirubin moves to the sinusoid, and from the sinusoid, as it is lipid soluble, the sinusoids, you know, here, as it is lipid soluble, can go inside the hepatocyte. This is a hepatocyte cell. Okay, this is a cell of hepatocyte. So what happens inside the hepatocyte? So we have our unconjugated bilirubin coming over here. So I told you that binding with albumin is not conjugation. This unconjugated bilirubin, in the presence of an enzyme UDP glucose transferase, that is a UGT enzyme, it gets conjugated. Two reactions occur. You must have read in biochemistry that monoglucuronide and diglucuronide occurs, two conjugations occur, and now this is called as a conjugated bilirubin, and this conjugated bilirubin is water soluble, so it can exist the hepatocyte. Can it exist the hepatocyte as it is water soluble now? No. So it will require the help of a transporter to exist the hepatocyte and reach the bile canaliculi, from which it goes into the portal tract, the biliary radicle, bile duct, gallbladder, and gallbladder concentrates the bile. The bile is concentrated, bile moves to the ampulla vater, and it reaches the enterohepatic circulation. Okay, the enterohepatic circulation of bile occurs and it helps in digestion, right? So basically there is a unconjugated bilirubin which is coming, and this is lipid soluble. Unconjugated is lipid soluble. It moves into the liver where the conjugation occurs, the hepatocyte conjugation occurs. Okay, and conjugated bilirubin, which is water soluble, exists via the transporter and reaches the bile canaliculi. From it moves to the portal tract, bile duct, gallbladder, and ampulla vater, and reaches the enterohepatic circulation. So jaundice is defined as more than 2 to 2.5 milligram per deciliter of bilirubin in blood, which causes the discoloration of skin, mucosa, and the eyes. Okay, the conjunctiva, the bulbar conjunctival icterus is seen. It is not scleral icterus. Sclera is not having a blood vessel, so it is, people say it is scleral icterus, but it is not scleral icterus. It is basically bulbar conjunctival icterus. Okay, and there is a yellowish discoloration, and the levels are more than 2 to 2.5 milligram per deciliter. What are the causes? We have a pre-hepatic cause before reaching here. Before reaching the liver, if there is any cause before this, okay, this is the liver point. Okay, this is the liver point. So if there is any pathology which is occurring before reaching the liver, it is called the pre-hepatic cause. It is called the pre-hepatic cause. So what is the causes? Hemolytic anemia. If the RBC lyses, okay, the RBC lyses, there cannot be causing, and there cannot be any conjugation. It won't reach the liver at all. So there will be increase in unconjugated bilirubin. So remember, whenever there is a prehepatic cause, there is an increase in unconjugated bilirubin, because conjugation will occur only if the bilirubin reaches the liver, right? Then we have our post-hepatic or obstructive jaundice. Post-hepatic and the obstructive jaundice. Okay, so here like bile duct tumor, gallbladder calculi, pancreatic head tumors. Okay, all of this can cause this, and this is a post-hepatic. Post-hepatic means after exiting the liver, if there is any pathology, after it exists from this point, if there is any pathology here in this level, either it may be any tumor or it may be any biliary thing, like the bile stones may obstruct it. Okay, anything which can obstruct the transport of bile away from the liver will cause this, like pancreatic head tumor, okay, or gallbladder stones, or any gallbladder pathology, or any pathology in the bile duct, okay, any bile stones, many of them. So bile duct tumor, gallbladder calculi, pancreatic head tumor, all of this. And most likely the patient will present a history of pleuritis. And pleuritis is the classical feature of obstructive jaundice. Okay. Then we have our hepatic jaundice. Hepatic jaundice means there is a problem in the liver itself. There is a problem in this level itself, the liver. There is no problem here. Okay, there is no problem here. There is no problem after that also. But there is a problem here at the level of liver. It's called the hepatic jaundice. So hepatitis and metabolic liver disorders cause this. What are the syndromes of hepatic jaundice? So hepatic jaundice has four important syndromes. One is Crigler-Najjar syndrome, one is Gilbert syndrome, one is Dubin-Johnson syndrome, another is Rotter syndrome. Crigler-Najjar, Gilbert, Dubin-Johnson, and Rotter syndrome. These are the four syndromes. Okay. So here Crigler-Najjar and Gilbert, you can remember like this. C and G means conjugation is gone. CG, conjugation is gone. Okay. So here, if the conjugation is gone, it is causing unconjugated biliruria. Okay, unconjugated hyperbilinemia. And here in Dubin-Johnson and Rotter syndrome, conjugation is present. Okay, conjugation is present. Unconjugated hyperbilinemia. Okay. So here, sorry, conjugated, not unconjugated. Here it is conjugated. Sorry. Yeah. So Crigler-Najjar syndrome. Let's come to Crigler-Najjar syndrome. Okay, also called as CNS, abbreviated CNS, is a genetic disorder, and it may be type 1 or type 2 diseases. So type 1 may be it is due to nil UDP glucuronidase transferase. There is a nil UDP UGT enzyme. Okay, so there is no conjugation at all. So only unconjugated bilirubin, which is lipid soluble. If it is lipid soluble, it can cross blood-brain barrier also and deposit it in brain. Can cause kernicterus. Kernicterus is a deposition of bilirubin in the brain, and the person will suffer from failure to thrive. He will not thrive at all, right? And type 2 is the depleted UDP glucuronidase transferase levels, decrease UGT level. So type 1 is nil UGT and type 2 is depleted UGT, right? So here there is unconjugated hyperbilirubinemia, okay, and UGT enzyme is basically a CYP enzyme, that is cytochrome P 450 enzyme. So the drug of choice, the treatment is phenobarbital. The drug of choice is phenobarbital. Phenobarbital is a long-acting barbiturate. Okay, so an ultra-long-acting, you can say an ultra-long-acting barbiturate. Phenobarbital. It is phenobarbital. If you have read pharmacology, you must have heard that the primidone, it gets converted into phenobarbital. Okay, so it is a pharmacological aspect. I will not go into that. So it activates the CYP and increases the UGT, and patient will live the near normal life. But here in type 1, the patient will fail to thrive. And diagnosis, enzyme defect, enzyme analysis is done, and liver biopsy will be normal. Since there is no problem here, the enzymatic defects are mainly occurring. There is no problem in the architecture of the liver, right? So that was the thing. And now let's talk about the Gilbert syndrome. Okay, let's talk about the Gilbert syndrome. Okay, in Gilbert syndrome, it is autosomal recessive disorder, and there is a decreased activity of UDP glucuronidase transferase enzyme again. Okay, and mutation is occurring in the Tata box, the promoter region. Okay, the UGT gene is present over here, and the Tata box, you know about the Tata box in molecular biology. So here there is a mutation in the Tata box. Okay, so the person cannot tolerate an increased level of bilirubin here due to this mutation, the decreased activity of UGT and Tata box mutations. Okay, so asymptomatic on-off icterus in adults. Okay, on-off icterus in adults, it occurs, and here the baseline levels are normal. Since the baseline levels are normal of the bilirubin, so the enzyme analysis won't act here. The enzyme analysis won't play any role here. So investigation of choice is the genetic analysis, in which I analyze the Tata box basically. Okay, now let's come to the Dubin-Johnson syndrome. Okay, DJS, Dubin-Johnson syndrome. It is also an autosomal recessive disorder and defect in MRP2 gene, multi-resistant protein 2 gene. Okay, MRP2, multi-drug resistant protein. Okay, MDR protein 2 gene, MRP2 gene, multi-drug receptor protein, multi-drug resistant protein. So bile hepatocyte conjugation cannot exist into bile duct. After conjugation, it cannot exist into bile duct. Okay, and there is conjugated hyperbilirubinemia. Understood? So microscopy, you will see that the bilirubin, basically the bilirubin here, look at this, it cannot exist here. This transporter is basically MRP2 transporter. Okay, and it cannot exist from here. When it cannot exist from here, there is an accumulation of the bilirubin inside the hepatocyte. Okay, and the microscopy will be the same. So there is a cholestasis. Cholestasis means the stasis or the stoppage of the bile, and it is intrahepatic. The bile accumulates in the hepatocytes. Okay, and this a lipomelanin pigment is also present over here. Lipomelanin pigment, you can see the black spots here, right? This lipomelanin, which is the norepinephrine byproduct, and it accumulates inside, giving a blackish discoloration. You can see over here, these are the hepatocytes, and here the yellowish tinge you can see. Yeah, so these are the cholestasis, that is the bile is now not able to exist, not able to exit the hepatocyte. Okay, here you can see the cholestasis and how it is occurring. Done. So what is the gross appearance? Due to lipomelanin presence, due to the blackish discoloration, the liver will appear black. Black liver is the gross finding. Okay. So that was about the normal histology and the jaundice. And now let's move to the hepatitis spectrum of disorder and alcoholic liver disease, alcoholic liver cirrhosis and all. And after that we'll move to the next chapter. Let's move on to the next part, okay, of this hepatobiliary system. So now we are into the hepatitis spectrum of disorders. So hepatitis we can classify like this. It may be a viral hepatitis or it may be an alcohol induced hepatitis, which is called as an alcoholic liver disease. Okay. And you can say that 80 gram or more ingestion of ethanol will cause a long term liver injury, and 160 gram or more will lead to liver failure or cirrhosis. Okay. And if this is there for 10 to 20 years, okay, the chronic exposure is important. Right? So what are the stages? So basically the first stage is alcoholic liver disease. Alcoholic liver disease progresses to fatty liver disease. Okay, the fatty liver disease, or it may be alcoholic steatohepatitis, that is fatty hepatitis, or alcoholic steatohepatitis. This fatty liver disease and alcoholic steatohepatitis can progress to the cirrhosis of liver. So cirrhosis of liver may be a fatty liver cirrhosis or a non-fatty liver disease, okay, which may lead to cirrhosis. So what is the metabolism of alcohol? Let's learn about the metabolism of alcohol. After that we'll see what are the things which you have to know. So alcohol is converted to acetaldehyde, and this acetaldehyde is basically hepatotoxic. And alcohol is converted to acetaldehyde by alcohol dehydrogenase. This acetaldehyde is converted to a non-toxic product by aldehyde dehydrogenase, right? So alcohol dehydrogenase and aldehyde dehydrogenase are two enzymes associated with the metabolism. Gender. Women are more prone to disorders of alcohol, that detrimental effects, you can say, of alcohol, like estrogen. Okay, estrogen releases an endotoxin which will cause more damage to the liver. Estrogen will release an endotoxin which causes more damage to the liver. That's why women are more prone to damage due to alcohol. Ethnicity. Some ethnic aspects are there, like Asians have a variant of aldehyde dehydrogenase, another variant of aldehyde dehydrogenase, by which they are not able to remove acetaldehyde much. Able to remove acetaldehyde much. Just pay attention to this fact. If they are not able to remove, this will accumulate and will cause more hepatotoxicity. So we Asians are more susceptible to hepatotoxicity. Okay. And talking about comorbid conditions like hepatitis B virus or hepatitis C viral infections may predispose the individual to grade 1 or first stage, that is the fatty liver stage. Okay. So let's talk about the fatty liver first. In detail. Pay attention to the pathogenesis, and okay, and then we'll go to the microscopy, and then we'll discuss the alcoholic hepatitis. Okay. So aldehydes, this acetaldehyde and other aldehydes will cause injury to the hepatocytes. This hepatocyte injury will cause a depletion of fat metabolism. The fat metabolism basically decreases, and due to metabolic causes also, NADH increases, and this NADH is utilized for lipogenesis. And this is due to metabolic causes. So this both factors, decreased metabolism of lipids and more production of lipids, is causing a fat accumulation. And also other etiology which may be there is the most common cause of fatty liver is the NAFLD. NAFLD is non-alcoholic fatty liver disease. Non-alcoholic means it occurs not in alcoholics. Okay, it is due to the consumption of trans fat. All the pizza, burger and you all are eating, that is a consumption of trans fat. Okay, and this consumption of trans fat also is responsible for the accumulation of the fats. So three causes we saw: aldehydes, which are generally hepatotoxic and cause injury, and this injury causes fat metabolism depletion, and metabolic causes which increase the NADH. This NADH causes lipogenesis and cause the accumulation of fats, And this NAFLD, non-alcoholic fatty liver disease, is basically due to increased consumption of trans fat, which is causing the fatty accumulation. All three factors are responsible for the fatty liver. Okay. What are the microscopic findings? Fatty liver means fat. Fat means fat will wash off when you process the tissue. So it may be the fat will appear clear. You can see the clear areas. You can see the clear areas. You can see here. You can see the clear areas. Okay. So the only fat in microscopy that is appearing clear. There may be a macrovascular steatosis or microvascular steatosis. Means what it means is that here either in a hepatocyte only one vacuole is present. Okay, one large vacuole, you can see one large vacuole is present over here. Okay, or it may be a microvascular steatosis. Microvascular means there may be multiple small vacuoles present. There may be multiple small vacuoles present. Okay, like this. See this. Understood? So here it is microvascular steatosis. You can see very small clear areas, right? Vacuoles, fatty vacuoles. Okay, so that was the thing, and here is a diagram from your Robbins textbook, and it is an important diagram. So normal liver, this is a normal liver, and whenever there is an exposure to other things, the alcohol and NAFLD, any metabolic causes, or consumption of alcohol, consumption of trans fat. Okay, the most common cause of fatty liver is consumption of trans fat only. So it changes to steatosis, that is fatty change. Okay, and if you continue the exposure, it will lead to cirrhosis of liver. There will be cirrhosis means there is a fibrosis and hyperplastic nodules will be seen. Understood? And a normal liver can also progress with severe exposure. If there is exposure, then steatosis and fatty change will only occur. Grade 1 fatty liver is nothing like every patient which you encounter can have a tendency to show grade 1 fatty liver. Okay, so it is not a very big deal as of now. Okay, understood? So there's no much problem, but grade 2, grade 3 fatty liver, grade 4 fatty liver are dangerous conditions. Okay, so first of all, you have to know that if there is severe exposure, okay, if there is severe exposure, then it may lead to hepatitis, and in hepatitis there may be liver cell necrosis, inflammation, and Mallory bodies are important characteristic inclusions in hepatitis and fatty changes. And the repeated attacks of hepatitis also can cause cirrhosis. This hepatitis may be occurring due to hepatitis virus, such as hepatitis B, C virus. Okay, and hepatitis, if there is absistence, to and the etiological agent is removed, it may progress to steatosis, and it may be progressing to the normal liver also. Okay, but if there is severe exposure to the steatosis also, it can lead to hepatitis. So you can see there is a interconversion that is going on. If you draw this diagram in an exam, it will be of good appreciation by your teacher, right? So now let's come to your alcoholic hepatitis. Let's discuss the alcoholic hepatitis now. Talking about alcoholic hepatitis, we know that this acetaldehyde is a toxin. Okay, and here is a normal cell. If it is a normal cell, it will destroy the protein CK. CK is a cytokeratin, and basically the cytokeratin 8 and 18 are destroyed. So this is a normal cell, and the protein CK, CK, that is your CK8 and 18 are destroyed. These are destroyed. Due to this, a dark protein, the cell architecture will be altered like this, and a dark protein starts accumulating, which is called as the Mallory-Hyaline bodies. The Mallory-Hyaline bodies. Okay, the Mallory-Hyaline bodies. And here the Mallory-Hyaline bodies are in the new literature. It is called as the Mallory-dense bodies. It is a non-specific finding, but have to know this. Okay, so we talked about this, that it destroys the protein CK, cytokeratin 8 and 18, due to which there is an altered architecture and dark pink protein accumulation over here, and this is called as the Mallory-Hyaline body. This Mallory-Hyaline body, the new name is the Mallory-Denke body. Okay, and it's a very non-specific finding and seen in any disease which will destroy this protein, to destroy the cytokeratin. And this Mallory-Denke body is not seen in acute fulminant hepatitis. It is a very severe condition. Acute fulminant hepatitis is a very severe condition, is a fatal condition. So there is a cell membrane destruction also, and it is cleared up by Kupffer cells. So basically this altered architecture is not present in acute fulminant hepatitis. in this acute fulminant, this whole architecture is broken. This whole architecture is all broken. The cell membrane is broken and it is cleared off by phagocytic cells, the reticuloendothelial system of the liver, that is the Kupffer cells, right? And also in hemochromatosis, this ROS production increases, and due to this it will also destroy the cell membrane and it will be cleared by Kupffer cells. So these two conditions, the myeloid antibody is not seen: acute fulminant hepatitis and hemochromatosis. So you can see here, this is a myeloid antibody here. Look at this. So a dark protein is basically accumulated inside the cell. Okay. So clustered inflammatory cells, you can see the inflammatory cell infiltration also, since it is an inflammatory condition, and a you can appreciate that increased eosinophilia is there. So there is a site of a necrotic hepatocyte. It is a necrotic hepatocyte. Okay, a myeloid antibodies are also present, which is indicated by the arrow. Okay, and in B you can see the accumulation of fat. The fat accumulation you can see in the cluster of inflammatory cells. You can see the cluster of inflammatory cells, the lymphocytes and all, and they are present. Okay, and here it is stained for cytokeratin 8 and 18. Okay, it is stained for cytokeratin 8 and 18, where it can be seen that it has collapsed. Okay, it has collapsed here. So cytokeratin 8 and 18 stained, it is collapsed, and a myeloid antibody can be seen. Okay, so that was about our alcoholic hepatitis. So we discussed fatty liver, we discussed alcoholic hepatitis, and if there is increase uncontrolled drinking, the person drinks uncontrollably, even if the person suffers from alcoholic hepatitis, then there is nothing, there is cirrhosis. Okay, there is cirrhosis. Cirrhosis is usually irreversible. This is irreversible. At UG level, you can consider this irreversible cirrhosis. Cirrhosis is irreversible. But in higher levels, some cirrhosis some irreversible forms of cirrhosis may be seen. Okay. So what is cirrhosis? It is a fibrosis of the liver with regenerative nodule. We saw in the diagram itself. It is given in your Robbins, fibrosis with hyperplastic or regenerative nodules, right? Okay, cirrhosis may be nodules are present, so on the basis of the number of nodules, it may be micronodular. Okay, not the number, the size of nodule. It may be micronodular liver cirrhosis, or it may be macronodular liver cirrhosis. Micronodular means nodular less than 3 mm. Macronodular means the nodules are more than 3 mm. Okay. So post-hepatic cirrhosis are generally macronodular. In alcoholics there may be a macronodular cirrhosis or a micronodular cirrhosis. Okay, and alcoholic liver cirrhosis is called as the Leynac cirrhosis. Okay, this is the important term. The alcoholic liver cirrhosis is called as a Leynac cirrhosis. Understood? Okay. So what is the microscopic findings? Microscopy, you will see your perivenular zone. It starts from the zone 3 itself. Okay, there is a damage. There is a pericellular fibrosis found, which is called the chicken wire fibrosis in initial stage. A mesh-like fibrosis is seen in the or a pericellular. Pericellular means if this is our cell, there is a damage here, and this is our cells, this is our hepatocytes arranged here like this. Okay, so damage occurs, this fibrosis occurs on the margins of the cell. This is called perivenular fibrosis. So it forms a pattern like this, the scales of the fish pattern. Okay, and some scientists saw it and it appeared like chicken wire. Okay, remember this chicken mesh appearance, the chicken wire mesh appearance. Yeah, perinuclear halo and chicken wire mesh appearance. Do comment on which CNS tumor we saw that. Okay, so chicken wire fibrosis is seen in initial stage, and later on it forms a uniform form of fibrosis. You can see the chicken wire fibrosis here. The blue stained portions are the areas of fibrosis, and maximum damage is in the zone 3. Zone 3 will suffer the maximum damage. Okay, and typical finding is the chicken wire fibrosis. Risk factor, increased risk of hepatocellular carcinoma, HCC. So liver cirrhosis can lead to a hepatocellular carcinoma. Okay, now let's talk about the liver failure, and then we'll talk about clinical manifestations of that. Liver failure Liver failure, it may be acute liver failure or it may be chronic liver failure. Acute liver failure or chronic liver failure. Understood? So acute liver failure means that patient has liver damage with encephalopathy and coagulopathy. Encephalopathy is present and coagulopathy is also present. Just a minute. Encephalopathy and coagulopathy, and is seen within 26 weeks of liver damage without a pre-existing liver condition. There is not a pre-existing liver condition. The person will show liver damage within 26 weeks of liver damage. The patient will present with encephalopathy and coagulopathy, that is bleeding disorders. What are the causes? Drugs like acetaminophen, that is paracetamol. Paracetamol causes acute liver failure. This paracetamol, basically paracetamol, when it goes to the liver, it produces a toxic intermediate that is called as NAPQI. Okay, you must have read in pharmacology. This NAPQI is basically hepatotoxic. NAPQI is hepatotoxic. So this is the main effect exerted by paracetamol. Hepatitis A and B may cause acute liver failure. Autoimmune hepatitis may cause it. Budd-Chiari syndrome. Budd-Chiari syndrome is thrombosis of portal vein. Thrombosis of portal vein is Budd-Chiari syndrome. This may cause acute liver failure. Ray's syndrome. Ray's syndrome is aspirin-induced hepatotoxicity. Aspirin-induced hepatotoxicity. Ray's syndrome in children, it may occur. Acute fatty liver of pregnancy may lead to acute liver failure. Okay. And Ray's syndrome is due to mitochondrial inability to metabolize aspirin. Aspirin is not metabolized, so it will lead to a syndrome called Ray's syndrome. Ray's syndrome. So we talked about the etiologies causing the acute liver failure. Acute liver failure, here the etiologies are drugs like acetaminophen, hepatitis A and B, autoimmune hepatitis, Budd-Chiari syndrome, Ray's syndrome, and acute fatty liver of pregnancy. 5 important etiologies. Let's come to chronic liver failure. So hepatitis B or C. Remember, hepatitis A and B can cause acute liver failure, and hepatitis B and C can cause chronic liver failure. Or alcohol may induce the chronic liver failure, or metabolic disorders rarely can induce a chronic liver failure. Let's come to clinical manifestations of the cirrhosis. So how the patient will manifest, how the patient will have the manifestations of cirrhosis. A patient with cirrhosis present to you, how you will present, right? So encephalopathy due to increased level of ammonia, there is a flapping tremor which is called asterexis. Here the patient will flap his hands like this, the flapping of a bird. This is called the flapping tremors or asterexis, right? Bad breath due to ammonia. Bad breath as a general term is called halitosis, but bad breath due to ammonia is called as fetor hepaticus, right? Bilateral parotid enlargement. Spider nevi is in the angle of mouth and precordial area. Spider nevi is a type of mole only, but it appears like a spider like that projection is present. A bluish color is there. Spider nevi is in the angle of mouth and precordial area. Due to increased estrogen, the tiny vasoconstrictions are occurring and is causing this. Ascites due to increase in portal vein pressure, as this is the cirrhosis has occurred. The pressure in blood vessels leading to the liver and leaving out of the liver increases, and due to which the ascites may occur. Ascites means accumulation of the fluid in the peritoneal cavity. Then it may lead to due to increased estrogens, association with increased estrogens, it can lead to testicular atrophy and gynecomastia in male also. Okay, so these are some of the clinical manifestations: encephalopathy, bad breath, bilateral parotid enlargement, spider nevi, ascites, testicular atrophy, and gynecomastia. Okay. Now let's come to the portal hypertension. Okay. So talking about portal hypertension, it is due to increase in portal vein pressure. Causes are prehepatic, post-hepatic, and hepatic causes. What are the prehepatic causes? Let's say thrombosis. So thrombosis will occlude the portal vein, and there will be no thing. And narrow portal vein may be a cause. Prehepatic is thrombosis and narrow portal vein. Hepatic cause any liver pathology like cirrhosis, amyloidosis, sarcoidosis. Okay, sarcoidosis. Post-hepatic are the causes like right heart failure. Okay. Constrictive pericarditis, this may be the causes. Clinical presentation is ascites, increase in fluid accumulation in the peritoneum. Portosystemic shunt, there is a portosystemic anastomosis, portosystemic anastomosis, and this is due to the increased portal vein pressure, due to which the abnormal dilatation of veins have occurred. Due to abnormal dilatation of veins, they are connecting to anywhere. Okay, so portosystemic anastomosis are occurring, and congestive splenomegaly have occurred. Ascites, portosystemic stents, congestive splenomegaly. So what are the forms of portal vein hypertension? What are the manifestations? It may be an esophageal varices. Okay, it may be an esophageal varices. Patient presents with hematemesis. Okay, hematemesis, esophageal varices, and it may be hemorrhoids or piles in the rectum. Okay, and caput medusae, you must have read in anatomy. This appears like this. The umbilicus is the watershed area, right? So the veins draining above and below are dilated and engorged. So this is called caput medusae or peri-umbilical veins. And also some portocaval anastomosis may be seen in falciform ligament, in the Bayer area of liver, and the retroperitoneal areas. The falciform ligament, Bayer area, and the retroperitoneal area not clinically significant. So that completes our hepatitis, alcoholic liver disease, liver cirrhosis, and all of these things in the liver pathology. And now we'll move to our fresh chapter now. Okay, now let's move to any other chapter.